I just want to welcome everyone. Today we have, the pleasure of actually having Dan Worsley present to us. Dan is, are you head of nuclear medicine, Dan, still or not?
As far as I know, yep.
How is that for a great introduction? So Dan and I go back a long ways. We went to med school together, and I think Dan ranked second or third in our class.
Now you're just lying.
No, not at all. And Dan has continued to impress us with all his work. Although I think back then I would have never pegged you for nuclear medicine. But nuclear medicine has obviously made great advances and changes. And I thought today it would be great to hear from Dan about VQ scanning. It's just one of those modalities that were sort of the only thing available when you and I trained to diagnose PE. And then it basically kind of got put aside when CT scan came in, but now it seems to be making a comeback because we're thinking more about CTEPH and just sorting out the sensitivities and specificities of these modalities. So we thought we should probably learn more from you. And if Ben does have an opportunity to pull up some cases, if we have time at the end, we could try to attack some cases.
Sorry.
I'm sure there'll be lots of questions.
Okay.
So thank you.
Yeah, no problem. Well, thanks for having me. I mean, when Agnes invited me, I really didn't think I could say no. So, but it's a pleasure to be here. I have no disclosure other than, as Agnes said, we were once classmates a long time ago. And actually, and surprising to me, we both ended up doing sort of fellowships at hospitals that had a very keen interest in thromboembolism. So it seems like we're just coming full circle here to meet back here and talk about this. What I was going to do is just give a brief overview of pulmonary embolism. This group hardly needs that, but and then talk to you a little bit about the imaging in acute and chronic pulmonary embolisms. And Agnes wanted me to talk about which test when. I'll go over some of the limitations, and then finally, just closing with a little bit about imaging in patients with pulmonary hypertension, which are sort of a special but small but special subgroup of patients that we see. I think as this group knows, the prognosis from pulmonary embolism is quite variable, and we don't have a lot of good data, but we've got old registry type data and hospital data saying that the mortality from this condition, if left untreated, is up to 30%. And if treated, you can have a great impact and improve survival. So, in the spectrum of diseases that you should know something about, ones that are potentially fatal but are potentially curative are the ones that you should probably know something about, which is why I think everybody going through is keenly aware of pulmonary embolism, right from the clerks to the medical students to the MSIs to the residents and the staff. If I just look at some of the complications related to pulmonary embolism, again, you folks probably know this better than I do, but certainly in large clot volume pulmonary embolism, you can get hemodynamic collapse, and these are the people who tend to die and probably don't even make it to hospital in the first hour. But if you do make it to hospital and you're lucky enough, you can still get recurrent pulmonary embolism, and I should say here, when I'm talking about pulmonary embolism, I am talking about thromboembolism. Other embolisms like fat embolus or air embolus or foreign body emboli, air emboli, have a different feature in the lung. So this is just thromboembolic disease. A complication that we do see not infrequently is hemorrhagic edema. And that's usually in the subacute phase of pulmonary embolism, coming a day or so afterwards. And we used to call this pulmonary infarction because it was a nice wedge-shaped opacity on the chest X-ray. Of course, it's not a pulmonary infarction because the pulmonary parenchyma is fed by the bronchial artery, which is completely patent in this. It's the pulmonary artery which is which is obstructed, and you can get a bit of hemorrhage and filling of the alveoli, which gives you that classic, or what we used to call pulmonary infarction. Another early complication, which is not seen often, but it can be catastrophic when it is stroke or infarctions in kidneys and spleens and other organs that have a high blood volume relative to mass. And this due to paradoxical embolization in somebody who's got a usually an undiagnosed ASD or patent femoral valley, which is perfectly fine when the left heart pressure is higher than the right heart pressure. But if the right heart pressure were to go up because you've got a large clot burden, you can get paradoxical embolization. So in terms of some of the late complications, most of these are due to the patient's pre-existing comorbidities, their lung disease, their cardiac disease, their cancer, which they've got, or their hypercoagulable state. We do see some, some late or some recurrent venous thromboembolism, and then probably chronic thromboembolism is being recognized more as a disease entity. We used to think most of these people restore pulmonary perfusion completely, and a large percentage of them do, but some don't, and they end up basically with chronic obstruction of their pulmonary arteries, and then a smaller subset of those, if the clot burden is high enough, is going to go on to develop pulmonary hypertension. The clinical diagnosis, I don't have to tell anybody here that it's difficult, overlapping signs and symptoms, none of them especially sensitive or specific, and a large percentage of patients with a DVT have got asymptomatic pulmonary embolism. I think one of the big strides that have happened in my career is that we're now treating this as a systemic disease, a thromboembolic disease, rather than when we were taught in medical school. It was really the chest and the respirologist who gave us this lecture, but this is of course beyond. Obviously, the chest manifestations important, but the disease goes beyond that. And somebody who Agnes and I know, Phil Wells, developed some of the criteria to try to figure out who's going to be at higher risk clinically, and got his name attached to these, and then had modified them to a more binary approach rather than the sort of low, intermediate, high probability, and you get various points for having various conditions. Another clinical scale that I came across, which I really didn't know much about, is more of it's a rule out test. If you've got none of these, you are unlikely to have pulmonary embolism. It makes sense, and I guess can be useful. I suspect it might be tough to find patients that have got absolutely none of these conditions. In terms of which imaging test and when to order or what to order, I mean, when to order is as soon as possible. I mean, pulmonary embolism is is one of those tests that do get done. We try to get them done within hours. Certainly try to get them done within the same day. Things can get muddy if you delay the imaging diagnosis. In terms of what to order, the ACR, or the American College of Radiology, has come up with a list of appropriateness criteria, where they used to have a 0 to 9 point scale where they ranked various tests for various clinical scenarios. They've now dropped it to the sort of green light, yellow light, red light, to the red light being usually not appropriate, the yellow or the amber light could be appropriate, and then the green being usually appropriate. And if we look at the clinical scenario here, which is suspected pulmonary embolism, but a low or intermediate pretest likelihood, and a low or a negative D dimer. The D dimer, because of its high sensitivity but astonishingly low specificity, has been sort of a screening test that's been adopted. And in this case, they say that really there's no imaging that is appropriate. Change the scenario and give yourself a positive D dimer. Now the imaging becomes appropriate with CT angiography and VQ scanning being the most appropriate. And then some of these other ones, triple rule out, if it was clinically indicated, perhaps one could do that. MR for pulmonary arteries, we don't do much of that here. And then a whole host of other tests that would be considered not appropriate. If we look at pulmonary embolism with a high pretest likelihood, at this point, the D-dimer apparently doesn't matter. And again, CT and VQ are the way to go. The patient population that you might see suspected pulmonary embolism in the pregnant woman, for the initial imaging, the preference would be to start with the legs, with the test that has no radiation to it, and evaluate the legs, and then consider it, and then a chest radiograph, and then again at some point consider doing either a CT or a VQ. If you look at in terms of which of these tests has the lowest effective dose or the lowest radiation dose to the mother, in most places VQ wins out. If you look at which one has the lowest radiation dose to the fetus, CT wins that out. So I always get a bit of a kick when people ask me, well, which has the lowest radiation dose? And my next question back is, well, do you want it to the baby or to the fetus? The lung scan, you do get a low but insignificant radiation dose to the fetus because of the scatter from the patient's lungs. In CT, no matter what gestation, the X-ray beam is so well collimated that the fetus doesn't get anything, but the mother probably gets a little bit more. In terms of which imaging tests should you do, even the nuclear medicine guy is going to tell you, I think, that in all honesty, that CT pulmonary angiography is the imaging modality of choice. I think we do VQ scans in patients in whom CT is contraindicated or can't be performed. Things like moderate to severe contrast allergy, high risk for contrast nephropathy, GFR less than 30 is a cutoff. The other problem that comes is patients who either get a lousy CT because of the increased BMI, or they can't go on the CT scanner table because they exceed the table weight. And also patients that have severe orthopnea or have difficulty lying flat. We're able to do the patient sitting up, standing up, and lying down, whereas CT you're obligated to be lying down. VQ scanning can also be done when the CT is inconclusive. Usually that would be like a diagnostic study. Usually the timing of the bolus is wrong and they didn't get the pulmonary arterial pacified appropriately. And of course, if there's a discordant clinical indication despite negative imaging. Here's what I just grabbed a couple of CTA cases. This is what we typically would see in the acute phase. The thrombus, the dark bit here, floats in the middle of the artery, and you get a target appearance with the contrast running around it. And when you see this is what most partially occlusive thrombus looks like. Totally occlusive thrombus is actually a little bit harder to see, although when it's a fairly proximal vessel, you can see it well. But here's where the vessel just disappears, or you don't see any or minimal contrast. And the more you get out to the periphery, these can be harder to diagnose. So this is the easy way to do it. This is the secondary sign, or another sign of complete occlusion, with partial occlusion of the pulmonary vessel, of course, being much more common. And in this case, lower lobe predominant, more common than typically more common than upper lobe. Here's a CT case of what we call a saddle embolus, or a large central embolus. So here's the main pulmonary artery branching into the left, and then the right pulmonary artery. And again, here's this filling defect sitting here, saddling the main pulmonary artery. You know, these are patients in whom typically, if they've got right heart strain, or they've got straightening of the septum, you might change your treatment approach in offering thrombolytic therapy up front prior to just or rather than just anticoagulation. One of the reasons why I think, I mean, CT came on in the 90s and really took off, and is a test that can directly look at the thrombus. Nuclear medicine is an indirect test. We don't see the thrombus directly, but we see the sort of perfusion defect that it causes. But the other reason why CT, I think, works so well or is used well is that a lot of patients that have suspected pulmonary embolism don't have PPE. And the CT can give you a secondary diagnosis, whereas a lung scan really can't. And so, I mean, metastatic bone lesion in this patient who's got suspected pulmonary embolism. Here's somebody with a bilateral pneumonia. So again, I think VGH did an audit a few years back, and the prevalence of pulmonary embolism and the number of CTs that are ordered is astonishingly low in radiology, something like less than 5%. So over 95% of people coming through with suspected PPE do not have it, and CT is going to be very good at showing you something else. I mean, here's just an example of a concordant CT and VQ finding. Here's the ventilation part, which is relatively normal. The perfusion part, this is the anterior view, posterior view, and you can see that this is the right lung, and the guy's got almost a completely occlusive thrombus in the right main pulmonary artery, and a partial occlusive thrombus in the left main pulmonary artery, and has got a large clot burden of pulmonary embolism. And again, the septum is straightening. There's some right heart strain here. This is a person who's probably got acute pulmonary artery hypertension with their acute pulmonary embolism and would be at risk of paradoxical embolization. So here's a case where the CT quality is just not very good. This is the pulmonary artery being opacified. The aorta is also opacified. The bolus is a little bit late here. The patient's a little bit thicker and has got a lot of extra adipose tissue. The scan quality is not that great. And then here, a normal VQ scan can be quite helpful in excluding pulmonary embolism. There's a number of pathways that people have developed for doing the CT. If it's positive, you treat. If it's negative, you look at the legs, and then you go on. And you guys know this as well. I think one of the problems with, or one of the things that's come up with pulmonary embolism, while it was vigorously embraced for diagnosing pulmonary embolism, but what came up is that all these papers about what they call the overdiagnosis of pulmonary embolism by CTA, when a test is too good. And this was noted because the incidence of pulmonary embolism was going up, yet the mortality from it was staying the same or going down. So there's a lot of push for was the CT picking up clinically insignificant clot? Is one of the functions of the lung, one of its many functions of the lungs, to filter out small clot, which we don't want to get into the systemic circulation? And the answer to that question is probably yes. And so, it's a little bit, there's a bit of a fine line here between your sensitivity and your specificity. And if you crank up your sensitivity, then you'll be at risk of making an overdiagnosis and then exposing the patient to anticoagulation and follow-ups that may or may not be needed. VQ scanning, which is what we do in nuclear medicine, is really the oldest non-invasive test for developing pulmonary embolism. It was I think used in the early 1960s. What we can do with this is certainly we can diagnose pulmonary embolism. We can look at the clot burden, assess clot resolution, and then the evaluation of patients with pulmonary hypertension, which I'll talk a little bit about. And then I think somewhat of an underutilized area is picking up a right to left shunt, which is again going to identify the patients with typically higher right heart pressures and who would be at risk of paradoxical embolization. As the name implies, the VQ has two components, a ventilation component and then a perfusion component. At all the hospitals in the Lower Mainland, this is ultra-fine technetium labeled aerosol is what is used. Gives us a very nice uniform distribution of activity, typically in the lungs. And for the perfusion part of the study, we use macroaggregated albumin. And here's just what the ventilation apparatus looks like. It's this machine here. The patient breathes this in, only takes 2 or 3 breaths, and then we're able to image the ventilation portion of the study. And here's just some tomographic images going from the front towards the back of the lungs, left lung, right lung here, of a nice normal looking ventilation study. I think most, at least all of the lung scans done here have moved to going to using tomographic imaging. And if you're sending your studies to a hospital that's not doing tomographic imaging, I would ask them why they aren't, and encourage them to do so. The macroaggregated albumin, as we talked about, human serum albumin, which is heated, and then the particles clump together, and they form these clumps of protein, which are in the majority of the part, you want them big enough that they'll lodge in the precapillary arteriole. So remember, I mean, you guys hematologists know, I mean, a red cell 7 or 8 microns in size, and so any particle kind of in this range is going to lodge just in a precapillary arteriole. Important that none of the particles are too big, because we don't want them lodging in the proximal pulmonary arteries. That'll be giving the patient a pulmonary embolism. So here, we inject the patient in a vein. It's going to come down the IVC into the right atria, right ventricle, and then in the absence of a shunt,
what the heck?
Is going to go out into the
Who said Mackay could come over?
And this is sort of
I
just
thought we had a pool rule, no Mackays.
Dr. Spicer, your mic is on.
Thanks, Ben. I'll just, and this is just a normal looking perfusion study. Again, tomographic images in the coronal plane. So these are top, bottom, left, and right. And then we're going from the front towards the back, looking at the pulmonary perfusion, which should have a relatively uniform distribution, with the outline here just matching the mediastinal contours. And there it is, just in the axial plane. And of course, we basically just scroll through this when we're reviewing these studies. There are some conditions where we're going to want to reduce the number of particles. Kids who don't have fully developed lungs have got less pulmonary vasculature, so we would decrease the number in those. Patients with the known right to left shunt, or those with known pulmonary hypertension, because of the decreased flow reserve, we would want to decrease the number of particles. And then in patients that have got functionally only one lung, you're gonna, we're not doing many single lung transplants these days, but they have been done in the past, or patients with a pneumonectomy. Prior to imaging, there's a couple of things we like to go through. Certainly with any test involving radiation, the patient's pregnancy status or lactation status, these aren't contraindications to the test, but we would like to know this before we get started. Again, those things that might make us want to reduce the number of particles which we inject: the pulmonary hypertension, lung transplant, pneumonectomies, no one shunts. We'd like to get some idea of the physician's pretest likelihood, for the simple reason that, again, it can be helpful in the Bayesian analysis, trying to figure out the post-test likelihood of the disease, and then usually the D dimers involved in that as well. And then, as with any radiology test, you want to look for some of the other previous imaging that's been done. Is there an old VQ study, a chest X-ray, a CT, something like that? So, and my slide's not going. Sorry, I'm just gonna see if I can fire this out again and see if we can make this work. Oh my gosh. Not sure why, but that stopped. We're going to see if we can just blow by this slide here, and there we go. Okay. There we go. So another thing, prior to imaging, we want to make sure if the patient does have asthma or some kind of obstructive lung disease, we would want them to use their bronchodilator therapy beforehand. In patients with CHF or a heart failure, we'd like to try to optimize them medically before we go ahead and do the study. In terms of what are the findings on lung scanning, the main finding is a ventilation perfusion mismatch. These are going to be pleural base wedge-shaped lesions with when I say wedge, with the apex of the wedge pointing towards the hilum. Typically one large segment or two or more subsegments is enough to call these pulmonary embolism. With pulmonary embolism absent, you either get normal perfusion, match defects, or reverse mismatch where the ventilation abnormality is actually larger than the perfusion abnormality, and mismatch that does not conform with segmental anatomy. This is a more difficult area, but I think most nuclear medicine physicians have gone to this sort of more of a binary style of reporting with PE absent, PE present, or a technically suboptimal study rather than the old low probability, high probability. So here's a case with the perfusion images on top, the ventilation images on the bottom. I've got coronal, a sagittal, and then a axial image here. And you can see on the ventilation image here, completely normal, but the perfusion is missing chunks of perfusion to the left lower lobe. Here it is in the axial plane where you've got a defect in the left lower lobe, which is normally ventilated. This is going to increase the patient dead space. And then again, on the sagittal, you can see that defect. Here's another one where these are the ventilation images in coronal, starting from the front and heading towards the back. And again, you can see in this case, multiple small and then a little bit of a larger perfusion defect here, all of these completely normally ventilated. Another defect down here, which is completely normally ventilated. So when we see these are the typical appearance of pulmonary embolism. Here's a case of reverse mismatch. Here's the perfusion imaging, here's the ventilation imaging. And in this case, the ventilation defect in the lower lobe is greater than the perfusion defect. This is typically going to be airspace, airway disease, atelectasis, and we've got hypoxic pulmonary vasoconstriction mechanisms such that if you don't ventilate a lung, you will decrease the perfusion to that and shunt the blood to lung, which is ventilated. Sometimes, usually in the case of a partial obstruction, that doesn't work, and you can get this. Reverse mismatch. The other feature that I've harped on about is the right to left shunt. This is what it looks like here. Here's a patient with a relatively normal ventilation study, multiple segments of VQ mismatch. And when you put the camera above their head, they've got activity in the brain. So when they get an intravenous injection in the arm, the particles are going to lodge in the first capillary bed they see, which in the absence of a shunt should be will be the lungs. But if there is a shunt, typically again at an undiagnosed ASD or a patent foraminal valley, then you can get activity into the systemic circulation. And again, similar to CTA, we've got protocols for VQ and when to do it, and usually involves, if the scan isn't helpful, then move on to the legs, and then if that's positive, you're going to treat. If it's negative, you're probably not going to treat. What do you do with discordant results? And so typically I think Doppler or ultrasound is a good test there, because if you can prove they've got thrombus in their legs, then treatment for DVT and PE are similar. I think it's always a good idea to review the studies with the radiology staff, and then you guys try to apply a clinical assessment. When it comes to follow-up imaging, this is a point I wanted to talk a little bit more about, and I came across this. I'm sure you folks, I know a couple of the people on this list. You folks probably know more of them, but this sort of blue ribbon panel of people who got together and put together a practice guideline on when to do follow-up imaging, and this was sort of their recommendation to assess the patient, and if they still got persistent symptoms, then typically at that point you would consider doing follow-up imaging. There's a bit of a time frame here. They say 2 weeks to 3 months is when they would be assessed. There was a nuclear medicine study that was done, published a few years ago now, which basically followed patients that had pulmonary embolism, trying to answer this specific question that, when should it be done, or should it be done, and then if so, when. And what they did at their unit is they had patients come for follow-up scans at 1 week, 1 month, 6 months, and 1 year. And they had what they had is you could get your PE diagnosis either by lung scan or by CT angiography. If you made the diagnosis by CT, you got a lung scan within 24 or 48 hours, and then again follow up done at 7 days, 30 days, 6 months, and about 1 year. What they showed is that in their population, the median baseline perfusion defect score was 8.2. What this is there's 18 anatomic segments in the lungs. There's 10 in the right lung and eight in the left lung. So what they did is they ended up counting up the perfusion defects to see how much of the lung was occluded, and they basically ranked them as whole segments or half segments, and then added them up. So they've got a population that has got a fairly high clot burden pulmonary embolism. This is almost 50% of the pulmonary vasculature being occluded. And when they looked at the restoration of pulmonary blood flow, they saw that it was incremental to about six months. And this is sort of the thinking, or the stuff that we even applied years ago. So it was nice to see that this was proven in a prospective study. And again, in their population, complete recovery was seen in 12% at 1 week, about 50% at 1 month, and just a little over 50% both at 6 months and 12 months. And again, no difference in improvement between that 6 and 12 month range. So again, they're under their scenario, their recommendation would be to do a scan at 7 months, which might give you some prediction of who's going to be an early responder and predict final recovery, and then probably 6 months or so after treatment, which might predict patients who would go on to get pulmonary hypertension. The scans at 30 days and 1 year are not going to be useful. If you guys are hanging in there, okay, I'll just move on, talk a little bit about pulmonary hypertension. I think this is a difficult, or can be a difficult diagnosis, but I think the evidence that we know so far is that a subset of patients who have acute pulmonary embolism, which, remember, was that thrombus floating in the middle of the vessel, which was partially occluding the vessel, will develop chronic pulmonary embolism. And when I say chronic pulmonary embolism, that's when the thrombus is no longer floating in the vessel, but it becomes typically plastered up against the wall of the vessel. It becomes endothelialized, and really I think what happens at 6 months is that all of that clot is endothelialized, and no amount of medication, even intraarterial TPA, isn't going to resolve the thrombus, because the drug isn't getting to the thrombus, because it's plastered up in the wall. I wouldn't recommend using VQ scanning as the initial test in the evaluation of pulmonary hypertension. Typically, this is going to be echo, and then followed by CT. But current guidelines certainly recommend VQ in patients who've got pulmonary hypertension to assess for the relatively rare but treatable form of pulmonary hypertension, namely chronic thromboembolic pulmonary hypertension. So in this case, pulmonary VQ scanning is quite good, and it's good for the simple reason that if you've got enough thrombus to give you pulmonary hypertension, you're going to get a scan that looks like what I showed you earlier with the multiple segmental regions of VQ mismatch. These aren't going to be the subtle cases of the patient with a 5th division pulmonary artery occlusion, but usually typically multiple and fairly proximal and complete occlusions. The sensitivity of a CT is a little bit lower, and so they, again, high specificity, but again, this is the data from multiple studies showing that the VQ is more sensitive and should be done in the setting of chronic pulmonary embolism. And again, because of its high sensitivity, it's got a good negative predictive value, which is really what you want. I mean, you'd like a test to pick up the disease, of course, but a normal or a near normal scan really excludes pulmonary embolism. And I touched on this a bit. We can do. Our old VQ scanning was done with just planar imaging, but most of us now are going to tomographic imaging or SPECT imaging, which really does improve the results. This is the note from the Canadian Cardiovascular Society and the Canadian Thoracic Society position statements, and again, once they've confirmed the diagnosis of pulmonary hypertension, somewhere down the workup cascade of somebody who's likely to have it, is to and they don't have an underlying lung or cardiac cause for it, is to do a VQ scan to branch out your treatment. And I think this is one of the American publications, but it basically is the same thing. And the Fleshner Society, which is a International Society of Chest Radiologists, again, basically recommend VQ scanning, but again, emphasizing the tomographic portion of it rather than the planar portion of it. CT angiography, it's great for some of the etiologies, but not as good for chronic thromboembolic. Really has a limited hemodynamic assessment, and the distal pulmonary arteries can be a little bit difficult, especially when they're completely occluded. MR really hasn't shown very much promise in diagnosing lung parenchyma. You can look at flow abnormalities and things like that. So I'll just show you a example here. This is actually a patient with pulmonary hypertension. These are both perfusion lung scans, but this is their imaging pre, and this is their imaging post thrombo endarterectomy. So again, here's a MIP image, or a maximum image intention image, and this is what the patient's lung looked like pre, and this is what they look like post thrombo endarterectomy. So in patients that are going for surgery who've got a large clot burden, in this case much more PE in the right lung compared with the left, and then you can see the near sort of normalization of perfusion following surgical extraction of the thrombus. Interventional radiology can also go after these thrombi as well, and can extract them. So that's kind of the brief overview or the outline that I wanted to cover. I mean, there is a case. I think, Ben, I think this is your case. So I didn't hear from you, but I kind of figured this was gonna come. So I don't want to put you on the spot, but or it puts me on the spot as well, quite honestly. But maybe I'll let you know this guy better than I do. This is the one you had phoned me about, or kind of emailed me about clinically, probably about a few months ago, certainly. I think you're still muted.
Oh, sorry. I do remember. Is this the one about the shunt, or is this another one?
No, I think it's a different one from the shunt. I think this is a guy that he actually had a CT, and they picked up chronic PE in a lower lobe, which was incidentally picked up, and he's got diabetes and a renal transplant. And we had done a lung scan on him. And this was the first lung scan back in, this is the first lung scan back in October. Ventilation study here, perfusion study here, vent perf. And you can sort of, I mean, he's got some clumping of the aerosol here, but the ventilation looks pretty good. There's a nice wedge defect here. Here's some decreased perfusion here, The ventilation looks not bad. There's again some central deposition here, but for us, and I actually called this VQ mismatch. I don't think it correlated well where this guy's chronic PE was, which was in the left lower lobe, and that area looked perfectly fine. When we look at his CT, and I tried to take the VQ study and then fuse it with the CT, you can see that he's got this sort of air opacity here, which is, I think, correlates quite well with the perfusion defect. But the perfusion defect on lung scanning seemed to be a little bit larger. And so again, even though I saw this, I'm going, I still think this is going to be pulmonary embolism. Sorry, I just have to get a call. I'm on call. Nuclear medicine, Dr. Urzi.
Oh, thanks, Dan, for multitasking.
Sorry, this is embarrassing. Do you know what? Can I give you a call back? Is that possible? Okay, perfect. That's great news. Thank you for letting me know. Okay, take care. Bye-bye. I'm sorry. We had a patient who was radioactive who needed surgery, so the OR got quite uptight about it, and I left them my phone number, and I kind of knew that was them, so I apologize for interrupting and taking the call, but it was sort of one of those important things. So sorry about that. Anyways, this is the case here, and then we actually did a follow-up scan in February after Ben called me and said, this doesn't look like pulmonary embolism, blah, 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 blah. And on the follow-up scan, these the defects that on the previous scan looked mismatched, look completely matched now. And again, looking, probably corresponding with that opacity that we saw on the chest CT. So it does show some of the limitations of the study. I think that some of the aerosol was basically getting distal to in this study here. Some of the aerosol was getting distal to the airspace disease and giving us what looked like a relatively normal ventilation in the face of an abnormal perfusion. When we did the follow-up study, like I say, it all looked completely matched and didn't look like pulmonary. So this was one where we somewhat confused the situation a bit, but I think this was good because I was able to talk to Ben, and we discussed what to do, and we figured that the follow-up imaging was the best thing to do. And I think it sorted out what was going on in this case. So, anyways, that's all I had. So I thought this was the case that Agnes or you guys wanted to show, but I don't have anything else. But I'd be happy to answer any questions or be part of any discussion that goes on as time permits.
I have a question.
Yep.
Is it okay if I start?
Absolutely.
Okay. So I have a very interesting case. Apologies, I didn't give you the heads up, but maybe I'll just describe him and see what your thoughts are. But this is a gentleman with heavy kind of comorbidity burden, known severe COPD, triple therapy, known CHF, preserved ejection fraction, drug user, and essentially what happened was he kind of middle of last year started getting respiratory distress, and then finally ended up emerged 2 months later. So it was kind of a insidiously progressive shortness of breath until he was basically bedbound. So he went to emerge, he got a CT scan, that was August 29th. And they called a left pulmonary artery filling defect, and he actually had a reversal, like the RV-LV ratio reversal to 1.3. So clear evidence of pulmonary hypertension, very suggestive evidence of pulmonary hypertension. And they kind of said, well, the appearance of this clot could be like a chronic clot or an in situ thrombus from pulmonary hypertension, less likely to be acute thrombus based on apparently on the imaging characteristics. And then he had a VQ scan 2 days later, August 31st, which did not show PE, but recognized that there were extensive parenchymal disease, emphysema. So probably, my guess is probably that's why. Maybe you can enlighten me on this. Is that why maybe it wasn't seen? And this idea of in situ thrombus from pulmonary hypertension,
Right.
Does pulmonary hypertension itself, very severe pulmonary hypertension, and would that mess with the perfusion part of the VQ at all? And would that skew results at all?
Right. Typically, no. So, I think pulmonary hypertension in itself, pulmonary hypertension due to severe COPD and loss of vessels and because of the emphysema and whatnot, that normally doesn't affect pulmonary perfusion. I mean, the number of particles that we inject is relatively low compared to the number of pre-capillary arterioles. So even in somebody who's got bad COPD and pulmonary hypertension, that's why we actually reduce the number of particles in that group, because they do have decreased flow reserve, but it really doesn't affect the VQ scan. It is a I'm not sure what to make of in situ pulmonary artery thrombus, except, I mean, that's what pulmonary embolism is, isn't it? And whether, I mean, are they saying it was caused by the pulmonary hypertension and some stagnant blood flow? That's, I mean, I guess it can happen. That's an unusual, that would be a very unusual case, I would think. And again, chronic pulmonary embolism, usually a sequelae of acute several years down the road. And again, normally there you're just getting pruning of the vessels, and you can get webs formed and things like that. But the vessel, the clot doesn't normally sit in the pulmonary, in the middle of the pulmonary artery. It's typically plastered up against the wall and things like that with that. So that, I mean, that sounds like an unusual case, but I mean, it sounds like the patient had enough lung disease to give their pulmonary hypertension, and again, with that's where the VQ study, I think, can help by ruling out thromboembolic disease as a cause, and then it doesn't help progress to all the other etiologies that it can be, but it does help rule out what again at one time was the only treatable cause of pulmonary hypertension. So
yeah, it's interesting. I failed to mention he had an ultrasound of the legs as well, which was negative for DVT, and he was seen by pulmonary hypertension clinic, and they didn't think it was CTEPH. They thought it was possibly WHO group 2 or 3. So, and I'm trying to pin them down if they think this turbulent flow or disturbed flow of blood in the left pulmonary artery is what caused this quote unquote in situ thrombus. But then why not anywhere else? Why not on the right side? Is also kind of
it's a bit unusual. I mean, you can get flow artifacts with a CT as well. So I mean, that would be something to consider. So it sounds like a very unusual case, and one where I hope the VQ scanning pointed things in the right direction, unlike this case. But it's these are complex patients, and and so it could be very, very difficult. I mean, back in the day when Agnes and I were in medical school, pulmonary hypertension was quite easy. It was chronic thromboembolism and everything else, and you didn't have to break down the everything else box. You just called it you just called it primary, and it really can't be treated, and the way you went. Now that's been advanced much further, but it can still be a diagnostic challenge. So interesting. Yeah, I mean, let me ask you guys a question, and Agnes, you can feel free to chime in on here. What do you think about a case where a guy's got what is probably a low clot burden pulmonary embolism, partially occlusive thrombus in some small pulmonary arteries, nothing left in the legs, and no other sign of DVT or source? is there ever a time you would is there ever a time you would not treat that guy and say, well, his stuff in his chest didn't kill him, he'll resolve that himself, he's got nothing left in his legs, he doesn't need the treatment, or the minute a radiologist says pulmonary embolism, even in the 5th division pulmonary artery, you say, okay, well, no, he's gonna go on anticoagulation for sure.
Yeah, so great question, Dan. I mean, as you started out, talking about how CT may be overly sensitive and we're overdiagnosing, sort of non-consequential, not clinically significant PEs. It's been difficult for us because when radiologists do say, PE, even subsegment PE, it pushes our buttons to anticoagulate.
Yeah, absolutely. Yeah.
It was also a recent study where they actually did take patients with just isolated subsegmental PE and randomized them to anticoagulation versus no anticoagulation. So they did do an RCT, and it showed the patients who did not receive anticoagulation, the risk of symptomatic thrombosis, right, over the next 3 months was about like 3.9%, right? And with a high, like the high end confidence interval of like up to like 9 or something. So basically that kind of told us, well, we're going to need to anticoagulate these patients. So even though imaging, it may not be impressive, clearly these patients are hypercoagulable, something is going on. And these were patients with a negative ultrasound, actually on negative for DVT as well. So really did sort of answer that question. Yes, if you guys are calling it a PE, we are basically obliged to anticoagulate. The only time we wouldn't is if the patient has a contraindication, like bleeding, sort of, right? But right now we are going to anticoagulate. And then, of course, now, if this was unprovoked, then, we're looking at indefinite therapy is kind of the trend now. And a lot of people certainly feel uncomfortable, like, especially if you have a young person who's otherwise seems well, to commit them to lifelong anticoagulation, it seems excessive. On the other hand, why would a young, healthy person get a PE? So then it comes down to, okay, is this really a PE or not, right? So then it circles back to you guys, like, how confident are we, sometimes these subsegmental PEs? And as you know, we've not done that gold standard study like we used to do, where all these patients would have gone, undergone a primary angiogram as the gold standard, right? Like, so segmental PE seems to have just kind of been introduced and accepted and practiced. And when, chest, CT, like when John Mayo says this is a PE, that is.
No, I think it's impossible to ignore. I actually asked the question and I think I knew the answer already. So and you answered it exactly as I thought one would. There's so many conditions that we can't do something about, and pulmonary embolism is something you can do something about, and like I say, have a significant impact. And so I think you're, like I say, you're sick, much in the way that you're stuck investigating it. Even, the minute even somebody from your group or your team mentions, well, it could be pulmonary embolism, and nobody had really entertain that, but the minute even the medical student says that, you're going, it could be pulmonary embolism, and then you're stuck, investigating somebody that you may not have otherwise, but once it's been raised, you're stuck, and then it can be a slippery slope from there, quite honestly.
Yeah, and I think, in some ways, unfortunately, because CT is so readily available, that people, you think PE, you investigate for PE, whereas you and I, when we trained, we couldn't get VQ scans after hours or over weekends, right? So you really kind of have to rely on your clinical acumen about, okay, how suspicious are you? But, back then, it's very possible that more likely that we over anticoagulated, because, on a Friday night and somebody that we think has PE, we can't do a VQ lung scan. Now we've anticoagulated them over the weekend. We finally get the VQ lung scan done on, Monday or Tuesday, but there's nothing, but we've already did it, right? So this was one of the questions I want to ask you, like, is it still true that, PE could basically resolve after 48, 72 hours? Like just like with the imaging that we have that's so sensitive now, are we likely to still pick it up after anticoagulation for 48, 72 hours?
Right. Yeah. I mean, I think it can. I mean, in that study I showed you that looked at, what would be considered the natural history of patients treated with pulmonary embolism, was it 12% resolved completely within the first week. So I'm thinking some of those people are going to change or at least resolve a little bit even within the first 48 hours, 72 hours, which is why I think getting the scan, when I said when to do it, it's as soon as possible. And I mean, we're lucky here that we have, a couple of world-class chest radiologists and readily available CT scans, and it's and I think it's a good thing, quite honestly. It can become burdensome when the system gets, when like I say, the number of tests for pulmonary embolism on this side of False Creek compared to the other side of False Creek, quite a bit different. Talk to the residents who work in both places, and they, and so there's certainly an awareness of it here, and then you can also use the pulmonary embolism to get the CT done within a few hours as opposed to a few days, which is always kind of helpful for your patients as well. So but I think the sooner the better. I mean, to your point about lung scans, we certainly do them on the weekend on call, so they are available. They aren't available overnight midweek, but then they've got a CT scanner sitting in Emerge that's running 24/7, so that is available certainly. So,
But I'm sorry, can you, Dan? So can you unshare, because I think I'm just
sorry.
will be the rest. If anybody has any questions, please just feel free. If you want. Perfect. Just because some people put their hands up and then it's just hard to see.
I'm so sorry. I'm so sorry.
Oh, no, don't worry about it. Any questions from anyone?
It looks like Tony, or okay, Tony, go ahead. Or should I read it?
Oh.
Tony,
yes,
sorry, Tony, go ahead, please.
Yeah, I'm commuting on a transit, so I'm sorry if it's not really going through well. It's a question about using the residual disease or the baseline VQ as a predictor for recurrence risk. Do you have any insight on that, or is that something that the nuclear medicine gets requested often?
Yeah. I think it gets requested often, and I think it is a usual a thing, because, and again, any resolution that's going to happen is going to happen by 6 months. What you've got at 6 months, you're going to have, and so I think it's a reasonable time to do it. You can predict who might be setting up for pulmonary hypertension. You're going to still see patients with some clot, but it might be a relatively low burden amount of clot, and it's not going to have any impact, and it's not going to give them pulmonary hypertension. But I think a baseline study can be helpful. The other thing is that once you've had a pulmonary embolism and you show your face to hospital down the road, and you've got pain somewhere between your mandible and your umbilicus, somebody's go, well, it could be pulmonary embolism, and so they're going, and so it's nice to have the baseline study to differentiate acute from chronic PE, because the lung scan by itself cannot do that just with a single test. But if you've got some serial imaging where you can look for change, then you can better differentiate that.
So Dan, Ben's got another question, but maybe I can sneak mine in. So if we're going to do a new sort of a baseline after treatment, 6 months, right?
Yeah.
Do you think it's better to do a VQ or to do a CT?
It's a good question, and it depends what you're looking for. Because if you're looking for chronic clot, which is what I think you are looking for at 6 months, then I think and again, we're kind of making the bit of an assumption that the when I say chronic, it's really the acute PE that didn't resolve and then become plastered up against the vessel wall. And CTA probably has a lower sensitivity for picking up that than does VQ. So that that the data would support that would be one of the indications for using VQ. In the acute phase, I mean, some people say they're similar. again, if I came in with pulmonary, I'd want to have a CTA, and I think, and again, because if you don't have it, you can find an alternative diagnosis, and it, in my mind, I even think direct visualization of the thrombus is better than the indirect visualization that we do on VQ scanning. So, but I think in the chronic phase, or 6 months down the road, I think it's very reasonable to do a VQ study at that point.
So can I just take that beyond that? So now then the patient comes back 3 months later with symptoms suggestive of PE, but now they get a CT, right? So then how do you compare a CT now for a query acute recurrence with your baseline VQ? Is that going to cause problems?
I mean, it can be. I mean, the sort of direct, we should be able to nail things down to which segments are involved or which parts of the lung are involved. If you can't say what segment the clot's in, it's probably a non-segmental defect, quite honestly. So I think you can correlate the results. Studies which have done that have been very, very challenging, and there hasn't been good correlation between clot distribution and burden on CT versus VQ, and even in the old days with pulmonary angiography and that. So it's a challenging area. But I would still say, in the acute phase, or when you're worried about acute pulmonary embolism or recurrent acute pulmonary embolism, CT is the way to go, and then VQ for the query chronic in the probably asymptomatic person who's coming off of or the mildly asymptomatic or mildly symptomatic person who's coming off of anticoagulation. And again, you're basically then trying to can you identify then a subset of the population that might be at risk for developing pulmonary hypertension down the road if they have further events or their burden of clot increases.
Thanks, Dan. Okay, 2 questions I have. So Ben, how good is the performance of VQ in predicting a true shunt? What kind of things might increase the likelihood of a false positive shunt finding?
Yeah, I mean, and I guess when we're talking shunts, we're talking right to left. So most of the time we're talking about shunts like VSDs or left to right. This is not that. So in terms of how good is it, to me, I think it's a gold standard test. It's better than echo. It's better than the bubble. We can actually measure the shunt fraction and how much is there. In terms of false positives, it really, I don't know that there's anything that can. If you're injecting 50 micron particles into an arm vein, again, it's going to lodge in the first capillary bed it sees, and those should be in the lung in the absence of a shunt. So if you see it in the systemic circulation, typically it's spleen, kidneys. We don't see liver because the liver gets bulk of its blood supply from the portal vein. So and then the brain, of course. Then that is the presence of a shunt. In terms of what we can't do very well is predict where did that shunt occur. Is that an avascular malformation? Is that a patent foraminal valley? Is it an ASD? Is it a precardiac? Is it a post? We don't do very well with that. So we're good at seeing the shunt. We're less good at telling you where the shunt. We usually say, well, in the setting of pulmonary hypertension, it's going to be the ASD because 25% of us are walking around with an undiagnosed patent foraminal valley or an ASD, and that gets that gets shown when you get increased right heart pressures.
Well, that's great to know, because I mean, often, we're dealing with these cryptogenic strokes, and, we're asked about, is this a paradoxical embolism and so on? We'll do ultrasounds of the legs, which I think are probably useless in most of those cases. But I have never thought about doing a VQ lung scan. I mean, we do those, and then sometimes, we'll push for a TEE type of thing if we're really suspicious. But
no.
I mean, if we could at least demonstrate there is a shunt, then then that would be the first step, right? Like if there's no shunt, then there's no point doing echoes. And I bet we can get a VQ scan faster than we can get echoes now, because that's 9 wait, right?
Yeah. And we do, I mean, honestly, we end up, anybody with a pulmonary hypertension, we take that that extra picture of the head. And so, you know, I mean, if you don't look for it, you'll never see it. And I think I've got colleagues that elsewhere who don't do that routinely, and I try to get them to do it, and they're asking us about pulmonary embolism, they're not asking us about a shunt. Well, they still want to know about it, because as you said, I mean, getting a stroke from one of these, from a DVT, it can be catastrophic, certainly. So
Yeah, great. Okay, now Emily's question. I'm just mindful of time, so I'm rushing a little bit. So Emily, suggesting all PE should get end of treatment VQ scan, or just those that are symptomatic?
Sorry, should all get in those who are symptomatic? That's a good question, and I think if the symptomatics of pulmonary embolism are the symptoms of PPE are so difficult that I'd probably say everybody should get to get a scan, because you would like to know what their baseline perfusion looks like. Did they resolve completely, or did they resolve incompletely but with a lower clot burden, or do they have a higher clot burden? So I mean, I think I don't feel strongly about it, but I think the getting a scan at 6 months on everybody certainly would not be a wrong thing to do. It's a relatively easy test. The radiation dose is less than a year of background in Vancouver. It's not a big deal from that point of view. So that would be my preference, but you're also talking to the guy who does this, who doesn't have to look at patients. So I would almost put the question back to you and say, would you find that help? Would you find a negative, obviously a negative test would be helpful. A positive test with a low clot burden would be helpful. I think if it can get a little bit confusing sometimes if you get confusing results, but I think I would do it. So.
I mean, I can say for me, like I almost always do it unless the patient is a clearly true, provoked clot, where I think the risk of recurrence is low. So the chance of me having to look at him again for query PE or DVT is low, right? Whereas the patients where, oh, well, it's a long distance, weak risk factors, I think the risk
unprovoked,
of be higher, then I always try to do it. But like I said, I wasn't sure whether I should do a CT or a VQ, but now actually listening to you, then I probably would actually get VQs in these patients. Much easier to do, I think, one thing too.
Yeah. Well, and again, it just boils down to what are you looking for? You're looking for chronic clot. And again, I think, the data, even from the radiology literature, would say that, CT doesn't do as well when the thrombus isn't floating in the middle and the contrast is swirling around it. And it's a much easier call to make in the acute PPE than it is in the chronic.
Thanks, Dan. So I think last question, because we're at 5:41. Any specific parenchymal abnormalities or anomalies we should watch out for that would reduce the accuracy of the VQ scan for PE? So, classically, we would, if there were parenchymal disease, and in the old days, we would never be allowed to get a VQ without a chest X-ray first. But I really see that request anymore.
Yeah, I spared you guys that slide because that was some of my own research, and I didn't want to show any of that. So I think it's a good question. I think the take-home message from me to you would be that if you could optimize the patient medically, make their lungs as good as they can be, dry them out from their heart failure, then send them for the VQ study. There's certainly the patient in some of the early VQ studies and the pilot study in particular that was done, they made a big deal about patients that had lung parenchymal abnormalities. VQ shouldn't be done because it's going to be non-diagnostic, and the concern there is this triple match where you get a ventilation abnormality, a perfusion abnormality, and a chest X-ray abnormality, which is exactly what that hemorrhagic edema, that early complication of pulmonary embolism that I talked about, is going to show. One of the things that we have now that the pilot study didn't have is the old film. So if you've got parenchymal abnormalities that have been there for a long time and they're not part of the acute issue, then they're not going to interfere with the diagnostic quality of the study. If somebody does have an acute pneumonia, or again curly B lines and pleural effusions and whatnot, then they don't normally get in the way. But I think again, optimize them medically and then order the VQ. The VQ study at that time. You know, I wouldn't, you know, certainly if we look at the diagnostic performance of VQ scanning, we do better in the outpatient emerge population than we do in the post-op surgical population, who's going to, all of them are going to have atelectasis, all of them are going to have some degree of airspace disease. But it, you know, it doesn't, this is again where tomographic imaging, I think, has helped, and some places actually do a spec CT, so we can do the perfusion part and the non-contrast CT part at the same time, and that as well, and that can help us, you know, clear out some of the parenchymal abnormalities as well. So it's challenging, but I'm, you know, for me that was older teaching that has probably evolved since that time. I mean, certainly, you know, if you ask me which is easier to read, a guy with a normal chest X or an abnormal one, it's clearly the normal one. But you know, the degree of abnormality and what the abnormality is and how long it's been there also factors into that. So that's a good question, though.
Thanks, Dan. I would, there's one more question, but I think it was just addressed to me about what, so, you know, 6 months, do we do it in all comers or only in those who discontinue anticoagulation? So what I tend to do is, I mean, clearly for the people who's going to stop anticoagulation, where I think there is a higher likelihood they may have recurrence because they had a weak risk factor or unprovoked, then I definitely do a baseline. In the patients who are continuing anticoagulation, I actually often do it in the patients with a high clot burden to begin with, because then it tells me where they are at after 6 months, because some of these patients do still have, you know, symptoms. And I just find, again, if they come back later with more chest pain or shortness of breath, and now I do another, you know, CT at that point or VQ at that point, I don't know if they got better and now have recurred, or this was really what they were left with at 6 months. Again, the large clot burdens where I think it would be helpful for future diagnosis, I do it. And because, I mean, you know, this is all I do. So, and those are the cases that give me trouble in making, you know, a decision management later on. So it's useful. And it sounds like Dan welcomes these VQ lung scans now, so we can send them all his way.
Well, I don't know. That wasn't the intention of this, but I just think it does have a use in the chronic clot, and then differentiating acute from chronic in the future. You know, effectively establishing a baseline for that individual patient, and they're going to be different for the individual patient. So thanks.
I think a great point I learned from you today is that, you know, after 6 months, basically that is it. And you don't need to, you know, repeat it at a year, or, you know, even if they're on anticoagulation, to say, oh, you know, after another year, are their clots going to be less, that sort of thing. So if 6 months is good, then that's great. Then I'm not repeating baselines over and over again, because patients push sometimes for that, right? Yeah.
Yeah. Yeah, I don't know why patients want imaging, but you're right. There is sort of sometimes a push for that, and but I, the old adage, if it's going to affect your management, order the test, but you should be able to tell yourself before you order it what you're going to do with the result when it comes your way.
Yeah. Well, it is 5:47. Thank you very much, Dan. That was very, very useful. I hope, again, my apologies. I, didn't introduce you properly. And it's always great to know we could reach out with tough cases, because they certainly frequently.
Yeah. No. We like you to come down to NucMed whenever you like. We're on the ground floor, Station 8, right at the end of the hall where nobody comes, right across from cardiology, but if you want to come by, please feel free. Our cases show much better on the monitors than they do on any slides that I showed you here, certainly. So.
All right. Thank you.